So it was very specifically to support to have support for clinical teachers or clinical trainers in the rural sites, and it was called the Decentralized Training Platform at the time. And that included regular workshops, including consultant visits, on-site support, so that we would visit the clinical teachers, and that we would also have additional visits by consultant. The second part of the contract was to support curriculum change at the university. So maybe to put this into context, at the time the UKZN had committed itself to drawing up a new curriculum that would have quite extensive longitudinal clerkships and be a lot more decentralized. So that was really what it was for. So the context of it, the rural block is in the final year at the moment. So this is part of the old curriculum. So there's 6 blocks of 7 weeks each. The total number is about 240 students. We have got about 10 sites all over KZN. So in the south we use Murchison and Harding. In the north we go to Manguzi, Mossveld, Bethesda. We go close to the Lesotho and Emmaus Hospital. So it's really spread all over the province. It's a very integrated block, so the students work clinically, but each of the weeks in the block focus on a different competency. So you may know the competency framework with like the CanMed's competency framework. So in one block they look at, for instance, the first block is being a manager and leader, and as part of that we ask them to reflect on their personality and how that works within the team in a rural block. And we ask them to do an assessment around resilience and self-management. So that's like one of the assignments. Another assignment goes into the community where they go out with the WBOTS discussion that we had about a bit earlier, and kind of see people in the community and then talk about collaboration and teamwork. So and a lot of the pedagogy of the block is underpinned by transformative learning. So there's some very deep reflection and learning that takes place. So I mentioned the curriculum change. So prior to starting the Succeed, this curriculum review and redesign was ongoing, and we wanted to use some of the Succeed support to manage this. But then in February last year, for a host of reasons, that whole process was stopped. I think the biggest driver for not wanting to engage in curriculum change now is the group of students coming back from Cuba, that like a lot of the staff was feeling there were too many changes all at once, and that we really wouldn't cope with doing so many changes. So in terms of the activities, what we did do over the last 2 years is that we have had regular workshops, roughly quarterly workshops. So they have been held in Pietermaritzburg and Pangeni. Actually yesterday and today we are having workshops as well that are being held. Yesterday was in Pietermaritzburg and today is in Mkuzi. So it's really to bring the training much closer to where the clinical teachers are. We're planning to do an evaluation of that training this year. And then we also, so the contents of the training I'll come back to in a moment. Then we also, during each block, each site gets visited at least once, if not twice. Some get visited slightly more for a number of reasons, like there are usually other projects that are going on in that site as well. During the site visit, we pretend as if we're visiting the students. Okay, but it's actually we're visiting the clinical teachers. So we spend quite a bit of time with the clinical teachers. We often do a ward round together with the student and the clinical teachers. And then recently we've started to do mini CXs. So the students actually present a patient, and then as a group we review them. The content of the training is kind of around this. It's called TCT, the Training of Clinical Trainers. It's a program that was developed by, I think, the Academy of Family Practice. It's the Academy that's brought it in, with Jill Edwards from the UK. So it's really it's a very nice training program that looks at a whole range of techniques and methods of how you can support clinical trainers, and how clinical trainers then can become better trainers for students. So it looks at giving feedback, it looks at like the mini CX I mentioned, it looks at how you teach skills, like a whole range of skills and tools. So that's what we do together with the clinical supervisors. One of our staff members has become a national trainer as well. So Tandazo Nkabinde is now a national trainer, and he's also the module coordinator for this block. And so for us, this program, or the Succeed, and the link with the TCT, has really kind of built the capacity in all of our faculty to become better clinical trainers. So that's really impacted on the undergraduate and postgraduate training within family medicine. Okay, so one of the other things that we included is that we Hoffi had introduced us to Kobo Toolbox, which is the app that he's used for that 90-90-90 app that he's just mentioned. So we've been playing around it since the beginning of this year, and I just want to show you a couple of numbers. So these are all the hospitals that we are using. So there's from Emmaus Hospital to Eshowe, and these are just the number of students, of patient contacts that have been uploaded, and I think it was yesterday morning when I sent the presentation through. Since then, there are about another 80 that have been recorded. So that's roughly 80 patient contacts by students in a day. Okay, so that's the kind of scope of it. So one of the things that we've included in there is where are you seeing the patient, and you see at the bottom it's A&E, wards, OPD, PHC clinic or CHC, and labour ward, and then we also included home visit, because they go out with the W-bots, and we wanted to conceptualize that is also a consultation. That's not tourism, it's like a normal consultation. Then most of them are acute, some like chronic and emergencies. Here's the HIV, so it's nearly 60% are negative. About 30% of patients that are being seen are positive, and about 12 or 11 and a half are status unknown. So it's similar. I was quite struck by how close that range is to what Hoffi showed about a bit earlier. Then the other question that we ask is the patient linked into community care? So again, both to sensitize the students, like you need to think about how you organize care and follow up. And it's like I've really found that I was surprised to see how many are linked into community care. So it's over 70% are linked, and about only 10% are not linked, like very clearly not linked, and others we don't know. Okay, so this I found a very interesting finding. Okay, so kind of part of the difficulty with many of these 5-year big projects is that in year 1 you say we are going to save the world, and by year 3 you realize no, actually maybe we must focus on peace in the Middle East. You know, so like the context changes and everything changes, so it's quite difficult to make these long-term plans. So the curriculum process, we haven't really made use of the consultancy at all. A big thing that changed for us is the whole terminology of decentralized training platform at UKZN, because what started to happen is that quite a few of the disciplines started training in Mpangeni and wanted to go to Madideni. So actually that shift to other regional hospitals has taken on the meaning of decentralized training platform. So the rural platform is not a decentralized training platform. That's just the rural block. So what? It's just confusing. So like a lot of these sort of things locally become quite confusing, and one needs to keep one's head cool. So the consultancy for the visits, we also didn't make very much use of, because actually our team was doing all the visits anyway. Then the training for clinical trainers in family medicine, I mentioned that we really utilized the support from Succeed to build a capacity for clinical training much broader than just the undergraduate program. And then I mentioned the app, and I showed you that as well. I think there have also been some shifts in Succeed, like much greater focus on 90-90-90, that in our contract, there was nothing about that at all. So when I met with one of the people from CDC, they're saying, but what are you doing in terms of 90-90-90? And I say, nothing. Like I know her well enough to be able to say it like that. But it's like, you get these shifting goalposts, and you say, like maybe we can, we are training people, and therefore they will go out there, and then they will solve the 90-90-90. It's like, let's think about an innovative way of making the links. And then also the shifting envelope of funding. So for next year, we're told we need to cut down quite a bit. And that's kind of, for planning purposes, that makes it quite difficult when you think, all right, let's use this pot of money for that. And, well, maybe it's not there, or maybe it is there. Okay. So going forward, we want to continue with the TCT training workshops. And then also as part of the grant, this year, 2018 is when, in the middle of the year, the very large group of students are coming back from Cuba. So we need to establish new sites to place students in. So we are thinking of opening at least 3, if not 4, additional hospitals. And so we are thinking of using quite a bit of the grant to train the clinical trainers in those hospitals, in the new hospitals. Okay. So also the increased support to the to the hospitals, and then the focus of the support on the collaboration students. So that is my story. I think one of the things that I just want to say, what's quite difficult to report on, is to report on Succeed. So because that is actually what we are here for. That's the support that we are getting from Succeed. But there are many activities that we are doing that are actually overlapping with what you guys are doing completely. So an example I mentioned during lunch is our students are doing QI projects, and kind of it builds in their curriculum, it builds from third, fourth, fifth into 6th year, where previously they do audits, then in 5th year they do a critical incident analysis and do root cause analyses. So they develop a whole lot of tools that they can use for QI, that then in 6th year, as part of the rural block, they do a QI project that is completely embedded within the hospital. So the hospital chooses what kind of project they should do. They often choose an area. So for instance, in one hospital they chose outpatients, and then one group of students looked at the resus trolley. Another group of students looked at all the forms that the doctors use on the desk. Another group of students looked at the triage. Another group of students looked. So it's like the hospital has got an agenda of saying, let's sort out outpatients. These are the areas that we need to sort out, and the students are really the people that are doing the QI projects. So that's one that's I was thinking, listening to the conversations earlier, that's for us, that it just fits in completely just like that. Great.
Thank you very much. I certainly didn't fall asleep there. Just waiting for the chicken and the egg story.